Good evening, everyone present here. I am Faraz from Clarnet. Thank you so much, all doctors, for watching the video. Clarnet is very proud to be a part of this session as a digital partner.
Good evening, everybody. It's my proud privilege to welcome you all today for the ICA Webinar, episode 128. We've been having webinars, weekly webinars on Wednesday, the same time for the last 2 years, and we are really very proud actually to have conducted them so successfully. They are so popular, and today we are conducting the 128th one, and the topic is spinal anesthesia. Can it be different? A very new topic of interest. Before we start, wish you all a very happy new year 2023, which is only a few steps away from us. Happy New Year to all of you. To become a member of the Indian College of Anesthesiologists, this is a very simple form, which all of you, the ones who want to become members, can download from our website, and you can fill it up, as well as it's an on-site, you can submit it, as well as the payment can be done for the registration and the membership. You can become a member. Join today. It's highly recommended. You will benefit. Our Yearbook of Anesthesiology, Volume 12, is now available on www.meripustak.com. You all can go on to that website and then purchase your copy. These yearbooks have been very, very popular, and I can show you this one also is going to be of great benefit to all of us. And Dr. Mukul is our editor. This is regarding the certificate course and the fellowship course in critical care echocardiography, which is under the aegis of ICA, and it is in collaboration with the ISCCM Bangalore chapter and the ITAC, Indian Association of Cardiovascular Thoracic Surgeons, which is starting from the 1st of January 2023. So you can go on to the details over here as it is written, deanICAnational@gmail.com, and get all the details from this. And surely you'll be very benefited if you want to join this certificate course. Next week, as usual, we have a very interesting webinar, which is, of course, of great interest to the students, perioperative management of COPD. We have different topics of great interest to the students and the adults. We have experienced panelists and moderators, and please do join at 7 p.m. next Wednesday, which is the 4th of January, 2023. Today, again, I would like to tell you that the topic today is spinal anesthesia. Can it be different? And we have a very experienced anesthesiologist who is going to actually tell us what it is, Dr. Naresh Paliwal from Amravati. Welcome, and he will be talking about these topics, the segmental spinal hypobaric. And for this webinar continues, we have two very eminent moderators. One, of course, is Dr. Baljit Singh. He is the professor and designate, the president and CEO and the president designate of the Indian College of Anesthesiologists. He was the past vice president of the ICA National, a scientific director of the Indian Resuscitation Council, ex-director professor at the GB Pant Hospital, and also professor and head now at the SGT Medical College at Gurgaon. The other moderator is a very good friend of ours, and he's professor and the HOD of the emergency department, Dr. Amrisha, and he is at the Bangalore, and he is, of course, has got a very wide work experience with several skills, not only in the ATLS and the regional anesthesia, but also the BLSs and the ACLS. And as of the present designation, he is heading the emergency department. So without ado, I would like to now welcome you all to our the webinar, episode 128, and I request Dr. Baljit to kindly take over. Thank you.
Thank you so much, ma'am, for your kind words. And as you have said, that today's topic is of special interest because what we generally do is spinal anesthesia day in and day out. And we don't do it differently. We just put in a needle in one of the interspace in the lumbar region obtains, yes, I put the drug in and we are done with it. But there is one gentleman here who is daring to do something different than what is normally done. And the topic also is like that. Can it be different? Yes, he has a lot of things to say that yes, it can be very different. He'll be talking about, the segmental spinal, hypobaric spinal, and continuous spinal anesthesia. And he has a lot of experience with regard to these. So he is currently the associate professor, as the slide shows there. And his institution is Dr. Punjab Rao Deshmukh Memorial Medical College, Amravati, and special interest in segmental spinal and CNBs. And his publications, I've seen his publications, the 4 publications are only on segmental spinal. So you can understand his specific interest in the spinal, in the segmental spinal particularly. Plus, he has 2 publications on Dexcat, and he has also won award for the best paper at ICA Maharashtra, the Nagpur city. And he has done more than 30 webinars in the last 2 years on segmental spinal only. So that shows his deep interest in this. So without wasting any further time, I would hand over the mic to Dr. Naresh Paliwal. And before that, I would like to express that it's a tremendous feeling to share the platform with my dear friend, Dr. Amrisha from Rajarajeshwari Medical College. We've been, known to each other for the last nearly 25 years. He has just come back from greener pastures in Middle East, and he has now settled there in Bangalore over there. So over to you, Dr. Naresh Paliwal. Please go ahead. Stage is yours.
Hello, am I audible?
Yes, you are.
Yes. First of all, let me congratulate the ICA for completing their 128th webinar in just 2 years. And also, I am very much thankful to President ICA, Dr. Sood Madam, then the eminent moderators of today, Dr. Baljit and Dr. Amrish, and all the office bearers of ICA for giving me this opportunity. And without wasting much time, I'll start with my presentation. The topic for my presentation is spinal anesthesia, can it be different? Now, we all know spinal anesthesia is what is routinely done is spinal anesthesia much more than a single shot hyperbaric bupivacaine. The reason to use spinal anesthesia with hyperbaric bupivacaine most of the time is there's ignorance about the modern anatomy of the spinal canal, ignorance about the other solutions, isobaric, hypobaric, then difficulty in performing subarachnoid block in lateral and prone positions. Most of the people, they do it in the sitting positions only. Difficulty in changing the acquired habits. Lack of knowledge about the anterior and posterior routes. Ignorance of the safety of thoracic puncture and unawareness about the continuous spinal anesthesia. So what can be different in spinal anesthesia apart from this single shot lumbar spinal with hyperbaric drugs? It can be either a segmental spinal, also synonymously known as a thoracic spinal. It can be hypobaric spinal anesthesia. It can be a continuous spinal anesthesia. So I'll be talking mainly about the segmental spinal in detail, and then in short about the hypobaric and continuous spinal anesthesia. So my topic for segmental spinal, I have changed it to use of segmental spinal in the 21st century, because there is changing scenario about segmental spinal. Some 10-12 years back, when I started presenting this topic, my title used to be segmental spinal, is it possible? But there was a lot of criticism about this, using higher lumbar or lower thoracic spaces for giving spinal. Everybody raised a question about the safety concerns in this technique. So I started presenting about the safety concerns in segmental spinal. But then during this COVID pandemic, when everyone wanted to avoid the general anesthesia, then many of the anesthesiologists, they tried this segmental spinal right from the freelance to the corporate setups, and then found it to be a very useful technique. And it became the most trending regional anesthesia technique during the COVID pandemic. Then there was a recent article in British Journal of Anesthesia about defining the role of segmental spinal in 21st century. You can see here, this was an article published in April 2022. And here the conclusions were very, just a minute, I'll just hide this. The conclusions here were very loud and clear. The conclusion I'll just read out. The TSA has been incorporated into the armamentarium of an increasing number of anesthesia around the world. The main rationale supporting its use is to avoid subjecting high-risk patients to general anesthesia while still providing a safe and effective anesthetic. Despite the absence of larger trials, there is evidence from small cohort studies and multiple case reports that TSA may be considered as a safe, feasible, effective alternative anesthetic technique and may be used in patients where other anesthetic techniques pose a higher risk. So it was, conclusion was very clear. Then in short about the history, the main important thing is in 2006, the new era on segmental spinal began when A. Van Zundert gave spinal at T10 for laparoscopic cholecystectomy in a patient with severe COPD. Since then, there have been many studies about it. Now coming to what is segmental spinal. The segmental spinal is term often used synonymously with the thoracic spinal. But even the low doses of the drugs used at higher lumbar levels can produce a segmental effect with sacral sparing. So the ideal definition is blocking out the required dermatomes, essential for the proposed surgical procedure with very low volume of local anesthetic, giving spinal near the targeted nerve roots. This often necessitates giving spinal at the lower thoracic or higher lumbar levels. Lower the volume or the dose of the drug used, more likely to produce a true segmental block. There are some factors which make segmental spinal feasible. In thoracic segments, the spinal cord is positioned anteriorly, leaving a significant space between the posterior dura and the spinal cord. Also, the thoracic nerve roots are very slight and thin, and the amount of CSF at thoracic levels is comparatively less. As the CSF is very less, there is less anesthetic dilution from the site of injection, and the roots are blocked easily. While the onset time for isobaric drugs at lumbar levels is little longer as compared to hyperbaric drugs. And also there is natural thoracic kyphosis at T765. Whenever you talk about the segmental spinal, there are few safety concerns which are always asked. Few questions are always raised. Can there be a neurological injury with dural puncture at mid to lower thoracic or high lumbar levels? Can there be a ventilatory impairment due to the extensive thoracic nerve blocks? Can there be a bradycardia and hypotension due to blocking of the cardiac accelerator fibers T1 to T4 and high spinal? And last but not the least is medical legal issues, as it is still to appear in the standard textbooks. Coming to the first major concern, damage to the spinal cord. This is a midline MRI of the spinal column. The cervical enlargement fills almost the entire spinal canal at the level. In the thoracic segments, the spinal cord is positioned anteriorly, leaving a significant space between the posterior dura and the spinal cord. At the lumbar level, the latter space disappears almost completely. You can see in the next slide very clearly, there is a significant space between the posterior dura and the spinal cord. This is diagrammatic representation of spinal cord at thoracic, thoracolumbar, and cauda inguinal level. Imbuloni and Guvia did a study on the low incidence of neurological complications during thoracic epidurals, and they measured the exact distance at various levels. They found the distance to be around 5.19 millimeter at T2 levels, 7.75 millimeters at T5 levels, and 5.88 millimeters at T10 levels. Also, Lee R. did study on the anatomy of spinal canal in different positions, that is supine, lateral, and sitting positions. And they found that the distance is more in all positions at mid-thoracic levels, especially the lateral and most in the sitting positions. You can see here at T6 level, it is 5.99 millimeters in sitting positions. This is the position which most of the anesthesiologists use for giving spinal. The spinal cord sits ventral in the apex of the thoracic curve. And when you ask the patient to sit with the neck flex, it goes further anteriorly. You can see here the distance between the antedura and the spinal cord on the left hand side, and the figure on the right hand side shows the distance between the posterior dura and the spinal cord. This is again midline MRI because of the angulation which is required to perform a spinal anesthesia at mid-thoracic levels. The angulation of around 40 to 45 degrees is needed because of the spinous processes, they are angled. The distance between the posterior dura and the spinal cord is further increased. You can see here the distance is almost 8 millimeters as compared to 4.5 millimeters at low thoracic levels. There are some additional points which favor the safety of segmental spinal. The incidence of neurological complications during accidental dural puncture in thoracic epidurals has been quoted to be very less. There are various studies about it, and the incidence of neurological complications after accidental dural puncture is very less. So that favors the safety of intentional dural puncture with a finer needle. Also, the many anesthesiologists unknowingly use higher number of thoracic spaces, especially in obese and parturients. When the intercostal line is not properly felt, they go on going space higher and higher, and they are unintentionally doing what is known as low thoracic or high lumbar spinal. In one study, only 29% were found to be correctly identifying the required intervertebral space for giving spinals. And also the level at which the spinal cord terminates is variable, maybe as high as T11, as low as L3 level. Palpation is not a good, not an accurate method to identify the intercostal line. Only 29 to 41% of the people can correctly identify. There is a margin of around margin of error around 3 to 4 spaces higher than what is palpated. But with ultrasound, the margin of error is just one level above the intended space. You can see here the intercostal line can vary. It can be L2, L3, L3, L4, or even above that L1. About the second issue of ventilatory impairment, the main inspiratory muscle of respiration is diaphragm, which is usually unaffected. The expiration at rest is a passive process, and a forceful expiration and coughing may get affected due to paralysis of anterior abdominal muscles. But because of the low doses of the drugs used, that usually preserves the coughing ability. Due to minimal motor weakness of abdominal muscles, there is mostly a sensory block because of the low doses of the drugs used. About the bradycardia and hypotension, the heart rate may decrease if the block extends T1, T4, blocking cardiac fibers. But because of the lumbosacral sparing and less venodilation in the lower limbs, the right atrial filling is usually maintained. The negative band bridge reflex is not initiated, and that sustains the outflow from intrinsic frontotropic receptors, maintaining the heart rate. Less hypotension is due to less venodilation. About the medical issues and litigation, now there is enough evidence to prove its utility in cases where it is most indicated. There are a lot of references nowadays. The utility can be proved in the cases where general anesthesia is either contraindicated or can be risky. Most cases of litigation are against regional anesthesia, but still the thoracic epidural is being performed day in and day out, even by the trainees. So if that can be justified, the intentional dural puncture with a fine needle can always be justified. Proper explanation and consent is must. It has started to appear in some textbooks. There are just mentioned about thoracic spinals in some textbooks, but till that time, we can keep our fingers crossed. There are 4 aspects about the feasibility: technical, economic, legal, and operational. Technically, it's not very difficult from your routine spinal, especially at the low thoracic spaces. It is as easy as your lumbar spinal. There's not much of angulation. It can be a little bit difficult at higher thoracic or mid-thoracic levels, but those who are doing it thoracic epidurals, they may not find it very difficult. Economic feasibility, it's very, very, very economic. Legal feasibility, still a question mark, but can be defended with strong indications. Operational feasibility, it can be operational at any sort of setups, right? From the freelance to the corporate setup, it has a good learning curve. about its utility, can be used for practically all intra-abdominal surgeries, be it upper, lower, open, lap, major, minor. Also for the breast and superficial thoracic surgeries, plus some awake thoracoscopic surgeries like mulectomy, thymectomy, lung volume reductions, and wedge resections. Also for some prone and lateral position musculoskeletal spine surgeries. Some advantages of routine spinal or at times for general anesthesia. Surgeries thought to be out of domain of spinal anesthesia, like upper abdominal surgeries, thoracic and breast surgeries, are possible with segmental spinal. Higher levels of the blocks can be achieved with just half the dose that is required at lumbar level. Minimal hemodynamic fluctuations, early recovery and voiding. Special advantages of general anesthesia in patients with respiratory comorbidities can avoid post-op pulmonary complications and ventilatory support in such patients. There is also lower incidence of post-op nausea and vomiting. There are 3 different modes of using segmental spinal. Either it can be a single shot spinal, short to mid duration surgeries up to 120 minutes. It can be combined with epidurals, either for long duration surgeries or in patients in morbid cases where you want to use a very low dose intrathecally. In those cases, epidural can act as a backup, and also by epidural volume extension technique, it can spread the low volume of drugs used intrathecally to wider segments. And also the epidural can be useful for post-op analgesia. And the third option is continuous segmental spinal anesthesia using spinocats by giving titrated and sequential boluses, especially in morbid cases or when you get accidental dural puncture during epidurals. Drug options, either isobaric or hyperbaric, can be used alone, or a combination of either of the three rather can be used. In general, isobaric drugs are preferred for laparoscopic, thoracoscopic, breast and superficial abdominal or major intra-abdominal procedures in morbidly frail patients where relaxation is not an issue. But hyperbaric drugs can be a choice in some male muscular patients when you want a proper relaxation. Hypobaric drugs, they are actually can be used along with iso or hyperbaric drugs, but they alone are not very useful for segmental spinal because of the low concentration and high volume of the drugs. They are at times unpredictable as compared to iso and hyperbaric drugs. So they can be used in combination with iso or hyperbaric drugs to achieve the desired levels. Advantages of isobaric drugs: they are preferred drugs as they are less sensitive to position issues. In low doses, they have propensity to block sensory nerves in preference to motor ones, what we call as a selective anesthesia. Onset is gradual, hemodynamic stability even with higher levels of block. Motor block time is usually shorter, leading to early ambulation and avoiding. Spinal can be given directly in the operative positions, like for lateral position surgeries, kidney surgeries, or ortho surgeries, AMP or the thing. You can directly give the spinal in the same position and continue. No need to change the position. Even can be given in prone position. Spinal can be given before epidural and at a space higher than epidural without worrying for unilateral effects. When using hyperbaric drugs, you need to give epidural first and then spinal. Then only one choice remains, that you need to give spinal below the site of epidurals. But with isobaric drugs, it can be given before epidural, and as it is given before epidural, you can give it a space above the epidural. Some disadvantages of isobaric drugs: levels of block cannot be modified by any change of positions, need to be placed at the precise dermatomes. Like in epidurals, sacral sparing is common when low doses at higher spaces are used. This is a disadvantage or advantages in upper abdominal surgeries. Takes some time for onset at lumbar levels. You need to wait for some time when you are using it at lumbar levels. Isobaric drugs, they take some time to onset. Slightly less muscle relaxation, need higher doses in male muscular patients, but these relaxation part is not much noticeable in morbidly frail patients. Unless you tell the surgeon, they don't notice it. Sensitive to temperature variations. These are sensitive temperature variations that can become hyperbaric when cooled and can become hypobaric when warmed at 37 degrees. So at times can have unpredictable results. Among the available drug options, isobaric drugs like chlorprocaine 1%, levobutyrocaine 0.5, ropivacaine 0.5 and 0.75%. And in the hyperbaric drugs, till date, only bupivacaine 0.5% was available, but now ropivacaine 0.75 and levobupivacaine 0.5% are also available. They all can be used. Chlorprocaine 1% is useful for short duration open or lap surgeries because it is 1%. The volume required is a little more, around 2.5 to 4 ml, and can work for a duration around 40 to 60 minutes. Levobupivacaine and ropivacaine. Levobupivacaine 0.5 and ropivacaine 0.75% are comparable. Ropivacaine, being less lipid soluble, is nearly half as potent as levobupivacaine intrathecally, and there is stronger differentiation between sensory and motor blocks with ropivacaine. Addition of small doses of additives like fentanyl, dexmedetomidine, ketamine, or clonidine can intensify the sensory blocks. Dexmedetomidine usually provides a longer duration than others in a dose-dependent manners, like 10 micrograms can provide a duration in excess of 3 hours with just 2 ml of the drug. The ketamine, though potentiating sensory block, is known to shorten the motor block time. These hyperbaric drugs can be used in the same dose range as isobaric drugs. Thoracic segmental can be produced with just half the dose than that is needed at lumbar levels. Onset time is reduced to reach the T3 levels. Then gravity-dependent spread has to be kept in mind when using hyperbaric drugs. Can be a better choice for open surgeries in muscular patients. Now, this is important, how to decide the dose and the site of injection. For abdominal surgeries, it depends on the type of surgery, site of surgery, average duration, and what the comorbidities the patient is having, and whether you are combining with epidural or not. Dose of local anesthetic and the site of injection along the near axis can be varied according to need. If you keep this in mind, that 1 ml of the isobaric drug spreads 2 to 3 segments above and below the site of injection, you can calculate the dose required for each procedure accordingly. What that means is 2 to 2.5 ml of the drug is sufficient to block segments from T2 to L5S1 if spinal is given at T10. 10 thoracic space lying in the center of the surgical field for abdominal surgeries. Dose and site of injection. With adequate dose, space about T10 is hardly required. Space between T10 L1 and a dose of 2 to 2.5 ml with some additive works nicely for 90 to 120 minutes. A regression of effects from lumbosacral roots. If you have not used adequate dose, below 2 ml, then the sacral root starts wearing after 70 to 80 minutes. And for surgeries involving pelvic manipulations, if you can anticipate the duration of the surgery beforehand, then the combination of hyperbaric and isobaric drugs can be used to prolong the effects at lumbosacral roots up to 2 hours. For breast and superficial thoracic surgery, spinal needs to be given at mid-thoracic levels with just 1.2 to 1.3 ml to maximum 1.5 ml with additive like fentanyl is preferred. With this much dose, it can provide duration of 60 to 90 minutes or little more if Dexmed is used as additive. With Dexmed, this much dose can provide you duration around 2 hours. For prolonged procedures, better to combine with epidurals or some blocks rather than increasing the intrathecal dose to avoid the adverse respiratory and cardiac events. Sorry. These are the levels required for different types of breast surgeries. Like for MRM, you need C5T7. For mastectomy with transverse rectus abdominis flap, you need C5L1. Partial mastectomy breast augmentation, just T1 to T7 is enough. The epidural scoring scale for arm movements, which is used to assess the thoracic epidurals, motor block in thoracic epidurals, can very well be used for assessing the segmental at mid-thoracic levels. There are 4 grades, 0 to 3. You can assess it by hand grip, C8T1, wrist flexion, C8C1, elbow flexion, C5C6. Position of the patient for giving spinal. With isobaric drugs, it hardly matters which position you use. Even lateral, sitting, or prone can be used. Plain levobupivacaine 0.5% with specific gravity of 0.9990 is slightly on a hypobaric side. And if you give the spinal in sitting position and keep the patient seated for some time, can lead to high levels of block. Temperature of the drug, as I have already mentioned, cooled at 24 degrees, it becomes hyperbaric. Warmed at 37 degrees, it becomes hypobaric. Wide variations in temperature can have some impact of gravity on the spread of drugs. Using two drug combination, sitting position is mandatory for giving spinal initially. Type of the spinal needle, either Quincke or pencil point, any of this can be used. Combined with epidurals. When you are using epidural with spinal, then CSE kit is the easiest and safest option. You can always locate the epidural space with epidural needle, and then it becomes more safe to use a spinal through the CSE kit. In one study, it was found that the paresthesia is more with the pencil point needles, as you need to enter a little 2 millimeter more inside the intrathecal space for free flow of CSF with pencil point needles. Incidence of paresthesia is more with pencil point needles, so better use Quincke needles. About the landmarks to identify thoracic intervertebral spaces, it can be by surface markings. You know C7 as a prominent spinous process. You can count it from there. Root of the spine of scapula at T3, inferior angle of the scapula at T7. The rib margin is around T centimeters away from the midline of L1. Then there is intercostal line, or you can take the help of ultrasound. You can count upwards from L5S1 in parasagittal oblique view. You can locate the 12th rib and go upwards, or locate the first rib and go downwards, and you can locate your required interspace for giving spinal. There are some anatomical hurdles for thoracic spinal. Thoracic spinous processes are sharply angled and point caudally between T4 to T9, but beyond T10, it resembles those in the lumbar regions. The interlaminar spaces in the thoracic spine are narrow and more challenging to access with a midline approach. So either a paramedian or a paraspinous approach can be used. These are some tips to follow for giving a paramedian approach. Around 1 centimeter away from the lower margin of the spinous process, then angle of 15 to 20 degrees medially, not more than that, and a cephalad angulation of around 45 degrees. To locate the interlaminar space, you may hit the lamina first, then change the angle and locate the interlaminar space by paramedian approach. But better approach is a paraspinous approach. You just go by the side of the spinous process and adopt the proper needle insertion and trajectory. I'll show you just short video about paraspinous approach. This is downloaded from the YouTube. You can just view the video.
Dr. Naresh, there is no sound.
It's very low. It's just showing how much angulation it should be kept. It's just 5 to 10 degrees. Just besides the spinous process, you have to enter. Too much of angulation can make you go to the opposite side, even inside the pleural space, opposite side. So it's always better to use just lateral to the spinous process. I think the video was clear.
The video was clear, yes.
Okay. Ultrasound imaging of the thoracic spine, as I already told, T10 to T12 are similar to your lumbar spine, but there is very small window in the parasagittal oblique view at mid-thoracic levels, and there is absolutely no window in the transverse view. What ultrasound tells us is the location to the interlaminar space, depth to the interlaminar space, and where exactly the midline is. In case there is deformities in the spine, scoliotic or kyphotic spines, you can do a pre-procedural scan to know that in scoliotic patients, the convex side is said to be more open. You can approach from the convex side in scoliotic patients. So if a pre-procedural scan is done, you can locate the depth and the depth to the interlaminar spaces. This is just to show how it looks in the parasagittal interlaminar view at the thoracic spine. the laminae, they look like a flat leaf-like hyperechoic structures at mid-thoracic levels. It looks like a sawtooth appearance at the lower levels, but here it looks like a flat hyperechoic lines with a gap in between. Through these gaps, you can locate the posterior complexes. The posterior complex is what ligamentum flavum and dorsal dura complex. And this is not always visible at mid-thoracic levels. It can only be visible in young patients. You're not sure whether it will be visible in every patient. You can also look the anterior complex spinal cord through this parasagittal interlaminar view at thoracic spine. The interspinous view at the thoracic spine is of no use because of the angulation of the spinous process. What you can see is the laminae, then on the lateral side, the ribs and the pleura. And the interspinous view is more useful at the lumbar levels, but hardly of any use at this thoracic spine. There can be a gap in the ligamentum flavum at times at the cervical and the thoracic spinal level. You can see on the right hand side figure, there is a gap in the ligamentum flavum it is showing. So you may not feel the loss of resistance at times when using a midline approach. This you have to keep in mind. Go slowly and remove the stellate to see for the free flow of CSF at every loss of resistance. There are some safety measures for successful use. You need to do a preoperative assessment of the patient, type, site of surgery, approximate duration, dermatomes, what will be dermatomes involved in the proposed surgery. If ultrasound facilities are available, you can do a pre-procedure scan, identify the landmarks to give the spinal selection of the proper drug and mode, decision on the site of injection and doses of the drugs required. And after giving spinal, assessment of the levels achieved, monitoring, and use of appropriate sedation as per need. In the preoperative assessment, apart from the site and type of surgery, you need to know about the duration, whether it will be short duration, mid duration, long duration surgeries, and accordingly you can choose your mode of segmental spinal. If there is a lot of comorbidity in the patient, if you want to use segmental spinal, you can use the lowest possible dose and combine it with this epidurals, or you can use the third option, that is continuous segmental spinal anesthesia using spinocats, where you can use a titrated small boluses of local anesthetics in such cases. This is a diagram to show the dermatomes. You need to know the dermatomes involved in that particular surgery. As I have already told you, for breast surgeries, you need to block from C5 to T7. Accordingly, you should know for every surgery. Coming to my segmental spinal profile, more than 3,000 surgeries in the last 8 to 10 years, initially for only high-risk cases, but now it occupies nearly 50% of my CV profile. Till date, there have been very few partial failures, but no mishaps. Conducted 2 live workshops and 1 face-to-face interactive workshop in 2022. I usually do a complete pre-anesthetic evaluation of the patient, emergency airway cart and drugs ready, venous access, minimum entry monitoring, no sedative pre-medications I use whatsoever. Lateral decubitus position, I prefer 27 gauge Quincke needle, table in neutral position, speed of injection is average. Depending on the patient, as I already told you, site type of surgery, the dose of local anesthetic and site of injection is selected. For short duration surgeries, I usually use chlorprocaine 2.5 to 3.5 ml with or without additive like fentanyl or ketamine. The additives which I prefer in these cases is also suitable for daycare surgeries. The additives which will give a longer duration of effect are not preferred, and those additives which will cause a nausea, vomiting, and respiratory depression are also not preferred for these short duration surgeries. For mid duration surgeries, either of the drugs, either isobaric or hyperbaric drugs, with some additives like fentanyl, ketamine, or Dexmit. Dexmit is preferred when longer duration is desired. According to the procedure, it can be from 2 to 10 micrograms. This is average for any intra-abdominal surgeries. You can keep this in mind. For average female patient, 2 ml plus additive, and for average male patient, 2.5 ml plus additive at T10 to L1 interspace. You can do any short to mid duration surgery with this much of dose, and at this site of injection, any intra-abdominal surgery can be performed. Combined with epidurals, the initial dose can be kept to minimum. You can keep as low as 1 ml or 1.2 to 1.5 ml. Then I usually combine these with either transverse abdominis plain block, rectus sheath block, or a rectus spinae plain block for open surgeries, or local anesthesia at the port site for lap surgeries. For breast surgeries, I prefer LEO VPVKN 0.5 or OPVKN 0.75%, 1.2 to 1.5 ml max with additives at mid-thoracic levels. And I usually combine with epidural or some interfacial plain blocks like PEC1, PEC2, serratus anterior plain block, or recently I have started combining it with erectus spinae plain block with full concentration of drug. It is giving a very good results and also the longer duration of effect. In short, about the two drug techniques for surgeries like TLH, PCNL, colorectal surgeries, where you want a dense and assure effects at lumbosacral roots, which is needed and which cannot be achieved when you use low doses of isobaric drugs at higher levels. Then you can combine this isobaric with hyperbaric drugs. It can also be useful for some high-risk cases of LSCS, gynec, and ortho surgeries. You need to give spinal in sitting position around T10 to L1 space, just 0.5 to maximum 1 ml of hyperbaric drugs, VPVKN, followed by 1.5 to 2 ml of isobaric drugs with some additives. Another two drug combination can be hypobaric drug along with any of the other two drugs like hyper or isobaric drugs. This is usually combined in cases like laparoscopic cholecystectomy, when you are using a very low dose intrathecally of isobaric or hyperbaric drugs. Along with that, you can combine hypobaric drug for this sparse and more cephalic spread, because most of the times in laparoscopic cholecystectomy, they give a head-up position, and that is suitable for spread of the hypobaric drugs. You can have involvement of higher roots without much of hemodynamic fluctuations. The patients are usually turned supine immediately after spinal and kept in lateral position for lateral position surgeries. Spinal sensory block usually tested with pinprick, usually sets in 3 to 4 minutes. Some hemodynamic fluctuations in first 10 minutes, usually gradual and minimal. No respiratory embarrassment is usually seen even with high thoracic cervical root involvements. Initial partial involvement of lumbosacral root depends on the dose used. No additional supplements is usually required in most cases, barring few lap surgeries when adequate level is not achieved. You may need some sedation to avoid the shoulder tip pain. Patients can be completely mobilized in 4 to 6 hours. To sum up, it's a very useful technique with many advantages. No need to panic, even if the block level is higher than desired. Lap surgeries may need little sedation. When facilities are available, ultrasound can be helpful. Technique is reserved for experienced clinicians with good learning curve. There is one new feature which I have recently added in this is do's and don'ts in segmental spinal. About the do's, before proceeding, know in detail about the technique. What are the various drugs that can be used that are available with you, doses, additives, and sites of injection. Know also about your surgeon. If you are not used to doing it with him, know whether he is used to doing the surgeries in regionals, especially the laparoscopic surgeries. Also know about his adaptability, flexibility, and how fast your surgeon is, so that you can choose your mode of segmental spinal according to his speed. Because what happens, the lap chole is a surgery which is done by different surgeons in different times. One surgeon may take just 10-15 minutes, one surgeon may take 2 hours. So you have to choose your dose and site plus the additives accordingly. Also know about your surgery, how extensive surgery is, what are the dermatomes involved, as an open lap, approximate duration, positioning during surgery. And also about the patient, whether patient is cooperative and willing for regional anesthesia or not. And about the comorbidities, risk-benefit ratio of general anesthesia versus segmental spinal. Then always use the position you are accustomed to or comfortable with, either sitting or lateral. Do a pre-procedural USG scan in difficult spine. Do use a CSC kit if you are combining it epidural. It makes your jobs very easy. Do always use multimodal analgesia with segmental spinal, either in the form of blocks, regional blocks, or some multimodal analgesia like paracetamol, diclofenac, or other additives which will not create post-op nausea, vomiting, and respiratory depression. Do prepare and keep ready your backup plan as always. Now, about the don'ts. Don't force your surgeon to do it under regional if he is not accustomed to doing it, unless there is a strong indication in favor of segmental spinal. Don't be rough and rusty. Be gentle, advance millimeter by millimeter. With every loss of resistance, just remove the stellate to see the free flow of CSF. Don't proceed if there is slightest paresthesia is encountered. Withdraw the needle and change the direction. Don't use high doses of local anesthesia at mid or high thoracic spaces to avoid the adverse cardiac and respiratory events. Don't unnecessarily add too many additives together. If you are not accustomed to using those or acquainted with their behavior intrathecally, use the additives which you are accustomed to, and if preferable, only single additive at a time unless you are accustomed to their behavior. Don't use excessive sedation with higher levels of blocks. What happens if you use excessive sedation with higher levels of blocks? The respiratory pattern may change and may disturb the surgeon, especially in laparoscopic surgeries. So unless you are planning to secure the airway, don't use excessive sedation. That will change the pattern of respiration. Don't panic with early hemodynamic interrespiratory issues when only low doses of LA are used in segmental spinal. Most of the times they are temporary, minimal and gradual, and easily manageable. The patient may complain of some breathing difficulties with high levels of block initially. That may be due to the initial hypotension, which is causing hypoperfusion to the respiratory center, and may not be due to the higher levels of block. So just wait and watch and see the hemodynamics, correct the hemodynamics, and it is corrected. Don't hesitate to call for help or communicate in case of any doubts. Now we will move on to other different types of spinal anesthesia, like spinal anesthesia using hypovaric drugs, in which either unilateral spinal anesthesia, posterior spinal hemianesthesia, and continuous spinal anesthesia. Spinal anesthesia with hypovaric drugs. Average density of CSF is 1.0069, and to make the drug hypovaric relative to CSF, you need density precisely below 1. It depends on how much distilled water you add. Accordingly, the concentration of the drug will change and the varicity will also change. If you add 3 ml of distilled water to 2 ml of plain bupivacaine, that is 10 milligrams, will make a 0.2% solution with a density of 0.9931. If you add 3.5 ml of distilled water to 1.5 ml of the drug, that will make a 1.5 milligram per ml and a density of 0.99815. Adding 4 ml distilled water will make a 0.1% solution with a density of 0.99726. It can be made hypovaric according to your need. The lower the concentration of the drug used, more likely to produce only selective sensory block. I mean, according to need, you can choose the concentration you want to use. For just superficial debridements and all, you can use a higher volumes, low concentration drugs for producing selective anesthesia. Basically used for anorectal surgeries in jackknife positions, also useful to produce unilateral hemianesthesia for lower limb and superficial thoracoabdominal surgeries. The posterior spinal hemianesthesia is a new term which is used, which is possibility when you use the hypovaric drugs and give spinal in the prone positions. There is a distance of around 10 to 15 millimeters between the anterior and posterior roots and between the right and left side roots. So when you use a hypovaric drugs in prone positions, there is a chance that you can produce only a sensory blocks. There will be no motor involvement. That is known as a posterior spinal hemianesthesia, and that can be used for superficial back surgeries. The procedure: prepare the hypovaric drug by mixing sterile distilled water as per the need. Either plain lignocaine, bupivacaine, levobupivacaine, or ropivacaine, any of the drugs can be used. But hyperbaric drugs cannot be made hypovaric by adding any amount of distilled water. This you have to remember. It will remain hyperbaric only. Even if you add 10 ml, 20 ml of distilled water, it will not become hypovaric. It will still remain hyperbaric. Even if there is 0.1% of dextrose in it, it will remain hyperbaric. So you have to take the plain isobaric solutions to make it hypobaric. For lower limb surgeries, spinal in lateral position with 15 degrees head down tilt and operative side up. Keep the patient in the same position for 10 to 15 minutes. This technique can be used for severe cardiac patients, lower limb surgeries with severe cardiac diseases. It will produce only a selective, mostly selective anesthesia with more of a sensory block and less of a motor block with not much of hemodynamic fluctuations. For anorectal surgeries in jackknife position, spinal can be given in the prone position with little head down tilt. Advantages are very negligible hemodynamic fluctuations, so can be used in high-risk cases, short duration surgeries. Low doses of the drugs used lead to preferential sensory block with minimal motor involvement. Early ambulation and discharge is possible. Can be used for daycare surgeries. Disadvantages is hypovaric drugs need to be prepared, so chances of contamination are more if not properly done. Less differences in the density between CSF and hypovaric drugs. There is only marginal difference between the densities of these two as compared to hyperbaric drugs. So they are at times unpredictable in their behavior and spread. Less muscle relaxation. If used for orthoscopic procedures, the surgeon needs to be accustomed to this less relaxations. So you may need for sedatives more often. Another method is warm the 0.5% BPA at 37 degrees. It will become hypobaric. Now coming to continuous spinal anesthesia, it's a continuous spinal anesthesia is producing and maintaining spinal anesthesia with small doses of local anesthesia injected intermittently into subarachnoid space via indwelling catheters. Actually, continuous is a misnomer. It can be actually graded or sequential spinal, can be a planned technique or modified after accidental dural puncture. It's very useful in several key clinical situations that are difficult to manage with either general anesthesia, single shot spinal, or epidurals alone. It's more rapid in action, more pronounced sensory motor blockade, fewer hemodynamic alterations and side effects. By reduction and fractionation of the induction dose of LA through the catheter, there is slower onset of sympathetic block that allows for the cardiovascular system to adapt more easily. So that's why it can be used in cases with severe cardiac issues. When to consider continuous spinal anesthesia? It can be either intentional or unintentionally. You can always think of using CSA in cases where there is difficult airway and prolonged surgeries, especially in morbid obese patients. For long surgeries, obesity patients for prolonged surgeries, patients with severe cardiac diseases, and also the patients who have previous spine operated and deformities in spine. Those can be the candidates for intentional continuous spinal anesthesia. Unintentionally, it can be when there is accidental dural puncture or when you need immediate analgesia for suppose if you are putting epidural and patient needs immediate analgesia for labor analgesia, you can choose a continuous spinal anesthesia. Equipments, microcatheters, actually FDA withdrew 510K approval in 1992 after concern or possible association with Koda-Ivana syndrome. But the Koda-Ivana syndrome was not due to the microcatheters, it was due to the drug accumulating in the caudal space, mostly the lignocaine. So microcatheters are now available again, and catheter or the needles are also available. The equipments for CSA can range from standard epidural macrocatheters to specially designed microcatheters. Even the pediatric epidural catheters of 24 gauge can also be used. It is sometimes difficult to puncture the dura intentionally with epidural needles due to the mental block we have. The specially designed spinal microcatheters, catheter or the needle sets. The kit consists of 22 gauge catheter or a 27 gauge Quincke needle or a 24 gauge catheter or 29 gauge Quincke catheter. This is not available with me, or I have not seen this. This is just a theoretical part. The Quincke needle has a fluid exit side hole that lays within the catheter. The needle is connected to a braided wire. The kit also contains a 18 gauge epidural needle. The technique is same as you do for combined spinal epidural. You locate the epidural space and then puncture the dura with the spinal needle. And once the dura is punctured, the needle is advanced a little further to have a free flow of CSF, then the braided wire and the spinal needle, and finally the epidural needle is also pulled back. Catheter then is connected to filter and fixed. The advantage of this catheter over the needle is less chances of PDPH, as the hole created by spinal needle is sealed by the catheter. You can see here in this picture, the catheter over the needle set, the hole created is nicely sealed by the catheter. On the left hand side figure, you can see the catheter through needle, where there is a leakage around the catheter because the hole created is bigger than the catheter. So this is the advantage of catheter over the needle set. The catheter through needle set, the microcatheters are also available nowadays, ranging from 25-32 gauge, the interlong sets, and other microcatheters. But catheters more than 27 gauge are difficult to insert. They can kink easily if force is applied, and once inserted, it's difficult to aspirate CSF from the catheters. Insertion of catheter more than 3 centimeters in the subarachnoid space increases the chance of catheter being caudally directed. It may go down, and the curled up catheters may sear nerve roots on its removal. Also, the pulling of LA in the sacral sac is an unsafe consequence of caudally directed catheters. It can lead to cauda inguinal syndrome. This is our routine kit of epidural, which can be used: standard 20 gauge catheter through 18 gauge epidural needle, or even a 27 gauge catheter through a 22 gauge pediatric 2E epidural needle that can be used. Advantage of this is free flow of CSF gives unequivocal confirmation of catheter placement. There is a very brisk flow of CSF through these catheters. This can be a primary technique or converted in case of accidental duropuncture. I'll just show a short video. Actually, I have my own video, but that is too long. So I just downloaded a video of using an epidural needle for continuous spinal from YouTube. You can just watch this video.
Especially in those elevated trauma patients who can't flex their lumbar spines well in a position. Check frequently for CSF to appear. There's no need to attach a loss-resistant syringe or gut capacity right through the epidural space. You may feel a pop or give as you pass through the ligamental flavor dura, but not always. Once you do get into the subarachnoid space, you'll know it. In patients with normal CSF pressure will flow like silk, even out of position. Do your best to stem the flow of CSF with your thumb. You're going to lose some CSF, and that's not a big deal. Just don't leave the tap running while you do the next step. Advance the catheter and remove the needle. The goal is to have about 3 to...
Just insert 2 to 3 centimeters inside. And then after inserting, you just check for the free flow of CSF by putting the catheter below the level of insertion site by gravity test. This is very important. You have to label the catheter in the bold letters that it is a spinal catheter and not an epidural catheter to avoid the misuse. If you are not going to use it post-operatively, you just have to knot the catheter, because it is always better to leave the catheter in place for 24 hours to avoid PDPH. Tips and tricks: prepare the familiar equipment with lower number of technical steps, avoid 2 small gauge catheters, introduce just 2 to 3 centimeters, actually, it's not 4 or 5 centimeters, aspirate CSF through catheter and filter, use small and graduate syringes, use epidural kit if no specific kit is available, remember the dead space, PDPH prevention, leave the catheter for 24 hours, inject saline before removal. This is advised by some, that before removing the catheter, you can inject 20 ml of the normal saline to avoid the PDPH. Clear identification and instructions of those who manipulate the catheter. Drug doses adjuvants according to the need. Either isobaric or hyperbaric drugs can be used. Usually 0.5 to 1 ml of the drug as the initial bolus. Testing the levels, you can use additional boluses of 0.5 ml every 5 to 10 minutes. Then every 45 to 60 minutes. If adequate levels not achieved with 3 ml of drug in 15 minutes, then abandon the procedure. Flushing the catheter after each bolus with normal saline is recommended, or otherwise you have to remember the dead space drug. Adjuvants like fentanyl, dexamethasone, clonidine, ketamine, midazolam can be used, and also can be used for post-op analgesia. Flexible soft quality catheters are preferred. Transient paresthesia is common during insertion, usually disappears after short length of insertion. Never withdraw the catheter back into the needle shaft, especially when using an epidural kit. There is the risk of sharing. If needs to be withdrawn, withdraw the needle and catheter together. High risk of infection, so keeping the catheter in place for more than 24 hours is not recommended. Keep the catheter in place for 24 hours. Strict labeling. Advantages I have already. Then in short about the continuous spinal lever analgesia. Who are the appropriate candidates? Parturients with prior back surgery, difficult placement of epidural, poor landmarks, morbidly obese in cardiac diseases, then high probability of cesarean section, potential difficult airway. Candidates with morbidly obese parturients with severe cardiac diseases, high probability of cesarean section, and patients with potential difficult airway. The advantages are excellent analgesia, no motor block, easy to determine proper placement, the route for delay of other medications. Decision to place the catheter intrathecally or recite epidurally after accidental dural puncture. So if you have a maternity unit familiar with intrathecal catheters, multiple attempts, difficult to position the patient, patient in severe pain, patient near delivery, laboring patient, non-reassuring fetal tracings, prophylactic blood patch not highly desirable. If answer to all this is yes, then place it intrathecally, or you can take a chance and recite the catheter epidurally. We know CSA is a reliable, flexible technique with improved patient satisfaction, but the question is, we already have a dural puncture with 18 gauge neutral and we are putting a 20 gauge catheter. So what is the risk of PDPH? Will that make her worse? Could it actually improve the situations? Once the dura is punctured, the initial reflex is to pull the needle out, but don't do it. The die is already cast, the damage is already done. So roll with it. You have a chance of providing the patient with a great anesthetic. Actually, the PDPH may be a lot lower when you put the catheter in for a continuous spinal. The risk of PDPH is lower when you put the catheter in for continuous spinal. And it is even lower in the morbidly obese parturients. Then suggested management of continuous spinal anesthesia for labor analgesia. It can be either in the form of continuous infusion with 0.1% OPVKN or 0.065 to 0.1% BPVKN with 2 micrograms per ml of fentanyl at 2 ml per hour. Or it can be a provider patient controlled top-ups of 1 to 2 ml every 15 minutes up to 3 doses per hour. Or it can be intermittent boluses of 2 ml of 0.1% OPVKN or BPVKN with 15 micrograms fentanyl every 2 hours. If patient needs cesarean, then you can give initial bolus of 5 to 7.5 milligrams of hyperbaric drugs. Then titrate the dose to desired levels with 2.5 milligram incremental boluses every 3 to 5 minutes. You have to take into account the catheter dead space. The risk of CSA for all practical purposes is similar to those of neurostial blockade. To reduce the risk of catheter breakage, while removing, withdraw it gently and holding as near the insertion point as possible, and keep the patient in flex position. The disadvantages are risk of infection, risk of PDPH cannot be used for more than 24 hours, but still CSA is a useful asset to have in every anesthesiologist armamentarium. And I think that I am done. And thank you very much for your patient listening for such a long lecture. Thank you.
Thank you so much, Dr. Naresh. And your
I think I was clear throughout.
Yes, you were very clear. The sound was quite clear. Your videos also were very clear. And what you said was absolutely very clear. The way you explained, I think things were very, very clear. Now, I would pass on to Dr. Amrisha. Dr. Amrisha, can you please start the discussion?
Yeah, I would like to congratulate Dr. Naresh for his excellent work, as well as doing a large number of
boring,
cases.
I think.
It
was not boring.
And no, actually, you see, when I was going through this in the history, way back when the landmark event came by August 1899, within 7 years, they have explained about continuous spinal anesthesia. They have done the thoracic, and in that thoracic segmental spinal, they have done head and neck surgery, laryngectomies, everything done. And they have said within a short time, this is going to become a very popular technique and this will this, but they were criticized. And I was going through and they were telling that the criticism, even after a centenary, it was told, suppose your family member comes for under this technique, are you going to say yes? If you are going to say yes, you accept this technique. So like that, I feel it is underutilized. And we have, until unless we do this in the institution, we train, and it will not be carried over. And like only a very few will be doing, like under what Dr. Naresh, who is doing. And I must compliment Dr. Sanish as well as our the ICA, Madam Sood, for having taken this initiative in getting this spinal, can it be different? You see, spinal has really established as a major in our practice, and more than how much, around 50 to 75% cases we are doing under spinal. But these techniques, some of the reports which you are seeing, patient with ejection fraction of 20, 30, aortic stenosis with respiratory problem, all has been done under this technique. Hypobaric technique, that was actually in the Snyder in the around 1950s. He has done, and he has told that this technique is really very useful for this one, that is flank surgeries, then this one surgeries. But still, we have been practicing the only this, and probably we are actually this is to be still done by the experienced people. That's what they tell, not by the routine, because the fear of causing cord damage, fear of catheter breakage. Then one time it was stopped in the 2017. They stopped producing the micro catheters. And presently they say that if you happen to get an epidural and there is a dural puncture, presently they are telling the options, go to the another page and this. Whereas presently in this it is telling immediately you put a catheter. If you keep the catheter for 24 hours in the spinal space, it gets sealed. PDPA chance is very, very less. So there is a lot of this one. So must I again compliment and congratulate for Dr. Naresh as well as our ICA for doing it. And there were some few questions which was put in the chat box. One you have already answered. Actually, it was asked, how will you prepare the isobaric and hypobaric with the present drug, what is available? Dr. Naresh, in your presentation, you have already answered that. Actually.
Yes, I already told you that only isobaric drugs can be made hypobaric. Hyperbaric drugs cannot be made hypobaric by any amount of dilution. That is a misconception. In just it will dilute the concentration of hyperbaric drugs by adding distilled water or normal saline to hyperbaric drugs. You cannot make it hypobaric or even isobaric. The hyperbaric drugs will remain hyperbaric.
I think this question had popped up before you had explained how to make a hypobaric solution from an isobaric solution.
Yes, hypobaric drugs, you can add the distilled water according to your need.
Agreed.
Actually, the amount of drug you want to use. If you want to use a lesser volume, you can just dilute it by even 0.1, 0.2 ml of distilled water, or just a fentanyl, addition of fentanyl can make it a hypobaric to isobaric drugs. They are already on the verge of being hypobaric, these isobaric drugs. And fentanyl is a hypobaric with density of 0.99, some 316. It is highly hypobaric fentanyl. So adding just fentanyl and little distilled water can make it hypobaric.
Yeah. Yes, Dr. Amrisha, you can please carry on.
Yeah, the plain bupivacaine also, for example, at the room temperature, and when it we are giving in the CSF with the body temperature, it becomes, which you have already told in your present, it becomes hypobaric actually. The temperature has also a lot of effect on this.
No, but that depends on the amount you are injecting. There can be initial decrease in the temperature of around 2 to 3 degrees when you inject around 2.7 ml of the drug. If you inject around 10 to 12 ml of the drug intrathecally, then there can be a decrease in the temperature intrathecally of around 6 to 8 degrees. But that is usually restored within minutes to your body temperature. So that does not make a difference. The gross differences in the temperature, like room temperature and your drug temperature, that can make the difference. Otherwise, there's such small differences. And also the density of CSF.
0.1%, what they have used in jackknife position, it has given the sensory as
Only
well
sensory.
as, yeah, and sensory block and analgesia was there around 299 minutes for those surgeries where you need not change. In the same position, you can do the anorectal surgery. And
Yes,
particularly this one is very useful, for example, fracture patient, let us say hip surgery.
Yes, I had done few cases of lower limb surgeries like severe aortic stenosis with hypovaric drugs. But the only disadvantage is the effect lasts for a very limited duration of time. Either you need to combine it with epidurals or some blocks with these hypovaric drugs. Effect lasts around approximately an hour with this much of drug. Just you are using just 5 milligrams of the drug.
Dr. Amrisha, can we go on to the next question?
Yeah, next question was there with regard to kyphosis and scoliosis. Dr. Naresh, they are asking whether this has any effect with regard to the level of blockade.
No, usually not. Only you can find difficulty in citing the spaces in kyphoscoliotic spaces because isobaric drugs, they usually depend more on the site of injection and the volume you have injected. Unlike the hyperbaric drugs, which are mostly dependent on the gravity for spread.
Yeah, and the other this one was there about the movement of diaphragm. When the surgeon was complaining, when this was done under this technique, the diaphragm moving, it is coming and frequently and interfering.
No, it all depends on the level you achieve. If there are adequate levels for laparoscopic surgeries, actually we test the levels to around T2, but the levels are quite higher than that, and that are mostly sensory levels. So if the levels are adequate, patients don't actually do such type of movements, and unless you use very heavy sedation, if you use very heavy sedations, the pattern of breathing can change and the diaphragmatic movements can disturb the surgeon. That's why I already told you. Unless you are securing the airway along with this, don't use very heavy sedations.
I think you need to fine tune the delivery of the drug to the required segment. And here the role of your knowledge with regard to the dermatomes which are specifically involved in that particular surgery is very, very important.
Yes, for average say 1 to even 3 patients, a dose of 2 ml in female and 2.5 ml in males is sufficient to block segments from T2 to L5S1 if spinal is given at T10. This is bold statement you can remember for all kinds of intra-abdominal surgeries of short to mid duration. Without calculating anything, you can use this much of dose, around 2 ml with some additive for any 60 to 90 minute duration surgery. Along with this, you can use multimodal analgesia with some block, interfacial plane blocks or multimodal analgesia, and that's done.
US FDA, no approval for dexmedetomidine intrathecal use.
At present, it's not approved, but there are many reports of its use, not only intrathecal, but also in pediatric and all cases. There are many reports. It's not FDA approved. There are many drugs, other drugs, which not FDA approved, but we are using it. But that gives a very good results, dexmedetomidine. But you have to use it and calculate the drug very cautiously. Even a little bit of more drug will keep your patient just paralyzed for even 5 to 6 hours, even with 2 ml of drug. That can prolong the duration even up to 4 to 5 hours. So you need to use a BCG or that 1 ml syringe to exact calculation in micrograms.
Actually, we did in our institute and recently we presented in the national conference also after seeing your spinal, that is segmental spinal. For breast surgeries we did. And of course, it was done by the experts only, not by the students. We did, and the cases were really excellent, and the patient had not much problem. And patients were also we asked them, they were very comfortable. And of course, we did all the simple breast surgeries. but you have done MRM and all those surgeries also under that technique. So I think there is a lot of this one to be started and initiated. There is one more question actually asking about the this one that which companies these catheters are available like that, marketing.
This I have recently acquired is from Pajung, interlong catheter.
I think Pajung has a lot of presence in various cities, so I don't think it should be difficult to get.
Yeah, I brought it from Mumbai.
Okay.
If anyone wants, can text me. I will provide the number, and they can get it from there. It costed around 6,400 for two catheters.
This is quite expensive.
Actually, the market price is quite high, 4,500 for a single, but for us it is around 3,200, 3,300 with tax.
That's quite a bit.
And they have used even the epidural catheters.
Yeah, I have. Till date, I was using epidural catheters only.
Yeah, pediatric size catheters has been used for this. And the other concern they were raised is what about the medical legal, which you have mentioned in your this one also, that you see in the standard textbooks, these are at least nowadays we see some mention about this and not much about this.
Unless there are a lot of studies and publications on this, the standard textbooks will not cover it. So you can always justify in cases where it is most indicated, because there are a lot of publications and reports about use, especially during this COVID pandemic. Everyone started justifying this use of segmental spinal. Otherwise, it was highly criticized.
Yeah, actually, of course, when you have seen the cases that were really high risk and it was done under this technique, if at all giving general anesthesia is really very risky in those patients. Considering the pros and cons, if you do this under this simple technique, they have done it, and this is really very useful. I remember during my one of the patients asked me, have you at any time received spinal anesthesia? Actually, he asked me, he was an educated person. Then I said no. Then he told, doctor, you must receive once, because the funny sensation that it causes after giving spinal, actually we won't appreciate it actually. In that way, the segmental spinal and the hyperbaric spinal, which you have shown in your this one also, that the motor, this one is spared and patients can ambulate early, and present day with the daycare surgeries and all, this is very, very excellent actually. So I feel there is a lot of this one to initiate and do these cases, not in a regular basis, at least for teaching the students.
At least when it is most indicated, you can always have this option. I'm not suggesting that you should do it in all cases, but most of the freelancers, I get daily feedback that most of the MRMs in our area are now routinely done. I think more than 100, 200 cases must have been done till date in last 2-3 months since my last workshop under segmental spinal. All the MRMs are being done under segmental spinal. It becomes very economic and patients are very comfortable. So they are choosing their techniques, they're mastering it. Those who are already using thoracic epidurals, they are finding it very easy just to give a single shot spinal through the CAC kit.
And when we go through it, is mentioning hyperbaric is the one which is causing more of cauda equina syndrome. Whichever the reports came, they were all using hyperbaric.
So because of the high concentration of the drug at the caudal levels, that was accumulating. Most of the hyperbaric drugs, they accumulated the caudal space, and that causes the cauda equina syndrome.
I think more than the hyperbaric nature, it was basically the concentration,
high concentration of the drugs.
And I think America has banned that concentration, which was associated with the incidence of cauda equina syndrome, whatever the cases were.
Yes.
What they were mentioning was the repeat dose. Suppose if we didn't add, we give repeated dose. So this repeated doses through the small catheters, what we are using, and these drugs doesn't diffuse and they get accumulated in a restricted space, particularly if it happens to be caudal, the catheter directed caudally. If it is cranially, probably they won't see this. So there it causes the neurotoxicity and cauda equina syndrome.
Yeah.
For diffusion of the drug, it will depend on the baricity of the drug. I mean, if you are using a hyperbaric drug and the patient is in the head-up position, it will go caudally. If the patient is in head-low position, it will go cranially. But for isobaric drugs, the diffusion is at the site where it is injected. According to dose, it will spread, involve the dermatomes. I mean, 1 ml will spread 2 to 3 segments above and below.
Yeah. Dr. Amrisha, I have one or two queries if you allow me.
Yeah, please go ahead, sir.
One is mainly related to the technical aspect of this technique, because if you are giving mid-thoracic, you have mentioned, 1 or 2 times that the needle has to oblique quite a bit, nearly 45 degrees in case you are going to the mid-thoracic segments. And if you go in the upper, third of the thoracic spine and or the lower third of the cervical spine of the thoracic spine, the angulation is not as much. So technically,
it is as good as your lumbar.
Quite right. So the technically to place the needle very precisely parallel to the two spinous processes through which the needle is going is I think quite a bit of challenge. Well, yes, with the kind of experience that you have, Dr. Naresh, I'm sure it would not be very difficult for you. But for a beginner, it may be sometimes frustrating, hitting the bone again and again, because to
you can take the help of ultrasound. Actually, at many institutes now, ultrasound is available. You can do a pre-procedure scan, or even you can do a ultrasound assisted spinal.
Well, yes, it's a question of the availability of the ultrasound at that time, for the patient. Quite often in the OTs, there is 1 or 2 ultrasound machines, and those may be used somewhere else. So the availability of ultrasound, of course, is quite a bit of question. In case it is available, certainly it's going to be of tremendous help. Other question with regard to the ultrasound, since you have mentioned that, do you determine your level or the spaces that you want to go through with the ultrasound, or you have your own?
No, ultrasound is what I am learning nowadays. I am not very expert in ultrasound. I am an old anesthesiologist. I am learning to do it.
How do you determine your spaces? Is it based on?
By anatomical landmarks, anatomical surface markings. And like I palpate the spinous process of C7 is the most prominent one. From there you can calculate.
From there you come down.
You can mark this scapula, root of the spine, the scapula T3, and inferior angle of the scapula.
Yeah.
But these are arbitrary, actually.
Quite right.
You can be a space higher or lower than what you are intended to.
Yeah, you
that
mentioned
hardly matters with sufficient dose.
You mentioned that with this palpatory method, the level of the space may be 2 spaces.
Yeah, it can be around 3 to 4, even 3 to 4 spaces higher than what you have intended.
That's
what is mentioned in the literature.
Yeah,
that it can be very difficult in especially obese patients.
Yeah. And how what is the longest case or surgical case time that you have had your patient with? Longest case with this
longest case
segmental.
Depending on the case, I choose my mode of segmental spinal. It is around 4, 5.
Your choice is all right. Your choice is all right.
With combined spinal epidural, it was around 5-6 hours.
Okay. So that of course there is addition of epidural, so you can continue.
Initial spinal takes care of around 2 hours. Then you have to supplement with epidurals.
Right.
Or with continuous spinal, I have done few cases. Those went on for 6 hours.
What about the barbotage? Do you do barbotage with?
No. Barbotage is it can create an intentional current initially, but it is even quoted in the this references that it hardly makes any difference.
Okay.
It's not advisable.
No, this is with regard
to not advisable. Does not make any difference.
Okay.
Though it can spread initially, but finally it depends on the baricity and the volume you use.
Quite right. All right.
Baricity and this thing, even the bevel, the direction of bevel, speed of injection, these things hardly matter.
With regard to the, you said the technique of, combined spinal epidural, you say that epidural should be given, and rightly so, above the spine, above the space where you have put in the spinal needle, or you are given the spinal. Now,
Yes.
when you place the epidural catheter, at a space which is higher than where you given the spinal drug, the tip of the catheter, you say that it should be
No,
at least 2 to 3 centimeters above. So my worry is that, won't the drug be delivered at a level higher than where it is actually desired to be?
no, I am not getting it actually. When I told about the advantages of isobaric drugs, I mentioned that spinal can be given before epidural and at a space higher than epidural.
Okay.
This is just to avoid the unilateral or saddle block when you use hyperbaric drugs.
Okay.
What happens when you use hyperbaric drugs? You cannot give spinal before epidurals. Otherwise, what will happen if you are using a sitting position? The patient will have a saddle block, or if you are using a lateral position, patient will have unilateral spinal by the time you site your epidurals.
All right.
These things won't happen with isobaric drugs.
Considering that you are to give epidural catheter, you put in epidural catheter, do you change the space at a level lower than, because the catheter, the length of the catheter would be at least 2 to 3 centimeters. That's required.
Yeah, at least length of the epidural catheter can be 3 to 4 centimeters, but intrathecal catheter should not be more than 2 to 3 centimeters.
Yeah, quite right.
Because there are chances that it may touch the roots in his course. And the intrathecal catheters are not advisable to be more than 2 to 3 centimeters intrathecally.
Right. With regard
epidurally, you can go 4-5 centimeters or even more than that.
Right. More than 5 centimeters is not recommended again, because
not recommended, but I mean, it won't do any harm, just other than coiling or unilateral this thing, but it will not harm in any way.
Right. With regard to the two drug techniques that you said, first hyperbaric and then isobaric.
Yes.
That's the sequence that you mentioned. So having given the hyperbaric drug first and then the isobaric, what about the possibility of displacement of the hyperbaric drug to areas more than where it would actually travel?
No.
If it was given
Actually, what we are giving is, when you are using these two drug techniques, we are using a sitting position. Okay. And we are using hyperbaric drugs initially, and very small amount, just 0.5 ml of the drug. By the time you inject your isobaric drugs, the hyperbaric drug settles down to the saddle area, and you get a dense saddle block. What is needed for your pelvic surgeries?
Okay.
And isobaric drug will remain at the site of injection and above, because it is slightly hypobaric also.
Yeah.
So it usually spreads above.
There was one case, I was surprised that an 8-year-old child, you convinced him to accept this technique, and he very comfortably had it, and he was even talking to the video. That was quite amazing. And which one is the lowest age group patient that you have given continuous spinal, or this segmental spinal?
Actually, I did a sickle cell anemia patient, 6 years old, lab colleague. Under this was long back. It was around 10 years back. Okay. A patient of sickle cell anemia.
Okay. I think apart from your skill in giving, administering these blocks, I think it's a skill in convincing the patient as well, or counseling the patient.
At times, we try to convince the patient when they are educated and all, but most of the tribal patients, they come in the very late stage. Like this DU perforations and all, they are at the end stage. You need to just tell the relatives that this is the technique I'm going to use, and this is the only option better for the patient. Otherwise, if you want the patient to be on ventilator or other setups, you can take the patient to higher centers. Okay. So most of the cases we do are with this technique.
There's one slide where you mentioned that in the prior back surgery, you had given continuous spinal anesthesia. Was it for, I think, continuous labor analgesia, if I remember it correctly?
No, that was for TLH, prior back. No, it was a prior spine surgery. C1, C2 fixation was done.
Okay.
And she also had some diffuse bulge at C4, 5, 6.
Okay.
These bulges.
So isn't locating the space a bit of a challenge, because with the scar tissue that's coming in your way, you're not very sure.
We we choose the
how much-
space accordingly. Actually, we avoid the operative area.
Okay.
That's the advantage of segmental spinal. You can choose any space. You can choose the drug accordingly. If you want a saddle effect, you can make the patient sitting and use a hyperbaric drug. If you want to use a higher levels with a lower space, then you use isobaric or hypobaric drugs. You can choose the drug and the space according to your choice.
Right. There was one slide where you mentioned that morbidly obese patients are less likely to get post-dural puncture.
PDPH. This is quoted in the literature.
Any specific reason? Any what logical explanation did they give?
Maybe due to the compression of the thecal space by the fat and all. For labor analgesia, it is most common is PDPH. That's why the CSA is not very popular with labor analgesia. But in morbidly obese patients, the quoted incidence is very less.
Okay.
Maybe due to this fat and all this thing compressing over the thecal space and the hole created by the needle.
Well,
I don't know the exact reason.
I think it was an amazing, talk, and it of course generated a lot of interesting questions. There were quite a few queries. I'm sure particularly the youngsters would have benefited from this talk. And I would like to, now pass on the mic to Dr. Jayashree Sood for the formal vote of thanks.
Good evening, everybody.
Good evening.
We've all been so engrossed in the webinar and benefited so much. Thank you so much, Dr. Naresh. That was excellent.
Thank you, madam, for giving me this opportunity.
Your expertise was just, exemplary. And we're all so impressed. And in fact, to tell the truth, we really don't practice so much as you do. And we've learned a lot. And definitely, as in the discussion, we've all said that a word of caution after hearing your lecture does not mean everybody should just goes ahead and starts doing whatever has to be done. Your words of caution have to be remembered, and everything has to be done very cautiously. So, and we were all very, very impressed. Thank you so much, Dr. Naresh. And thanks for the moderation, Dr. Baljit and Dr. Amrish. As usual, it was very well moderated. Thanks a lot. Thank you, everybody, and bye-bye. Good night.
Bye.